Thank you so much. And it's such a pleasure to be here and to be presenting this webinar for Pearson. I will be talking about the broadening spectrum within the hour's time. There isn't enough time to go into real detail on conducting a comprehensive diagnostic evaluation, but I'll be alluding to those components as we discuss the complex cases. I do have to disclose that I do receive royalties for my authorship on the books and on the Vineland, and that I consult on clinical trials that use the Vineland as an outcome measure. Here are your learning objectives for the webinar. And someone asked about the electronic copy of the slides, and I do believe that they are going to be made a bit available for everybody. Just very briefly, want to go over the diagnostic criteria for autism spectrum disorder in the DSM-5. There are two hallmark areas of delay or impairment, and these are deficits or delays in social communication interaction, and with young children, that would be play skills. And then the presence of what we call restricted, repetitive, and stereotype behaviors. There have to be at least two of these, and there are many. These are your repetitive motor mannerisms, your need for sameness and routine, difficulty with transitions. There can be sensory processing impairments, whether you're seeking out sensory input or you're having hypersensitivity to sensory input. And then you can have high fixations on topics, objects, or things. Then the DSM-5 has criteria for autism, and these also have to be met when we are providing this diagnostic label. The symptoms have to be present in early childhood. It's a neurodevelopmental disorder, and it's unfolding over the first few years of life. And all the DSMs prior to the 5th edition, this actually stipulated prior to the age of 3. But now that the spectrum is broadening so much and we are getting more subtle and more complex cases, sometimes you don't see the full-blown symptomatology until maybe 4 or 5. And in some cases, we'll talk about the syndrome goes missed until adolescence and even adulthood. The symptoms also have to cause clinically significant impairment across contexts in life. I, as a clinician, am not in the business for giving a diagnostic label of a clinical disorder to someone with a quirky personality. These symptoms really do have to be troublesome across areas in life. And the disturbances are not better explained by intellectual disability or global developmental delays in young children. And we'll talk about that in more detail. Then, in addition to giving the diagnostic label with those conditions, there are clinical specifiers that really help inform the profile of the individual so that it can then inform treatment and intervention. So you have autism with or without accompanying intellectual disability or developmental delays. You have autism with or without accompanying language impairment. And this is a good place to describe the type of language. Maybe the individual has phrase speech, but it's mostly stereotyped or echoed, meaning repetitious speech. Or maybe they have full speech, but it's still not used for communication and social interaction. Or the individual is minimally to nonverbal, which is important to know. And then you're saying the autism is associated with a known medical or genetic condition. We'll talk about genetics in a little bit, but there are many different genetic disorders that are highly associated with autism. And then now in the DSM-5, we can actually provide a co-occurring diagnosis of ADHD with autism, which in the preceding editions of the DSM, it was saying you couldn't provide both of those conditions, that if someone met criteria for ADHD, but they also had autism, those symptoms of hyperactivity, impulsivity, and attention difficulties were just subsumed under the diagnostic label of autism. And then finally, the research does show that in some individuals, enough to make it part of the clinical specifiers, can experience some catatonic symptoms, and we'll talk about this in a little bit as well. And then finally, we have severity levels for autism, levels 1, 2, and 3. Level 1 would be the most mild, level 2 would be moderate, requiring support, and then level 3 would be the most severe. These would be the individuals with severe and profound co-occurring intellectual disability and or language disorders that need lifelong care. These levels, you're providing levels for both areas of impairment. So I could give a level 1, for example, for the social communication and interaction impairments, but a level 2 for the restricted and repetitive behaviors and vice versa. The statistics for autism are ever changing. Every 2 years, the Centers for Disease Control here in my hometown of Atlanta conduct an epidemiological study, and this is for the United States. And the most recent one that was conducted, the prevalence rates in the general population are 1 in 36. We are now looking at over 2% of the population being diagnosed with autism. It's about 4 times more prevalent in males than females. We'll talk about those sex differences in a minute. The average age of diagnosis in our country is 4 to 5 years of age, yet we can reliably diagnose autism by 18 to 24 months. Just yesterday, diagnosed a 19-monther. This is something that is still really concerning in our field, that there's a 2+ year gap between when we can diagnose autism and when we are diagnosing autism, because that gap are the years, months, etc., of missed opportunities for intervention. And then co-occurring intellectual disability, these rates change as well. Right now, we're looking at about a third of the spectrum having co-occurring cognitive impairment. In autism, we're looking at a highly genetic disorder, probably one of the most highly heritable of all complex neurodevelopmental disorders. If a family has one child with autism, their risk of having a subsequent biological child jumps from that 1 in 36 to 1 in 5. And then another 1 in 5 chance that the child will have some of the symptoms of autism, but not enough to meet full criteria. We call this the broader autism phenotype, or shadow symptoms. And then another 1 in 10 biological siblings will have non-autism developmental delays, things like language delays or cognitive delays, but not full-blown autism symptomatology. So you definitely want to watch those siblings very closely, especially when we're talking about complex cases, because for whatever reason, more often than not, the younger siblings who are subsequently diagnosed tend to have more subtle symptomatology than their older autistic siblings. When we conduct comprehensive diagnostic evaluations, there are a whole bunch of components. There's screening and detection that usually happens on the front line in pediatricians' offices, in daycare, preschools, in schools more generally. And then those positive screens are referred for more further evaluation. When we conduct an evaluation, we are doing developmental and cognitive assessments to look at the baseline and the profile of cognition, because in autism, it's the norm to have scatter, not evenly well-developed skills. And then same for speech, language, and communication profiles. We want to see what those look like. And then because we're talking about 35 or so % of co-occurring intellectual disability, which requires adaptive behavior assessments, we're also doing assessments of adaptive behavior. I'll also discuss the importance of adaptive behavior assessments in addition to just co-occurring ID. It's important for understanding the profile of autism as well. And then you can really get into additional testing like executive functioning and social emotional regulation skills when you're conducting a diagnostic evaluation, because so many of those behaviors are overlapping with the co-occurring and or diagnostic differentials that we'll talk about. And that's all before we even get to assessing the autism symptomatology per se. And when we're looking at autism symptoms, it's twofold. Because it's a neurodevelopmental disorder, we are conducting a very comprehensive developmental history with a parent, caregiver, family member, or whomever. And then we're doing direct diagnostic testing with the individual. And then we're determining the outcome, right? And if there are any co-occurring conditions. The take-home message is, no matter what measures I talk about today, and I'm not even going to be talking about all of them, no single measure diagnoses autism. We as clinicians diagnose autism, and that's a very heavy burden on our shoulders. We are just relying on behavioral observations and all the tools in our toolbox to put together this diagnostic formulation. We will not always get it right, And that's okay. It's okay to be very transparent with parents and families and say, you know what, I'm on the fence. You have a really complex presentation. There are a lot of co-occurring things going on here, and it's all right to be transparent like that. The diagnosis comes down to the label equaling services, right? So we want to just get as close as we can with that label to meriting the comprehensive services that are required for autism. So when we're diagnosing using this in the research or academic field, we call it the clinician best estimate. These are the things that complicate the diagnostic picture or profile in autism that I'll be talking about today: age, levels of cognition and language, sex and gender differences, overlapping symptom expression in those co-occurring conditions, and then all sorts of disparities that can murk the waters when we're trying to make a diagnostic call. Starting with variations in age, the DSM criteria were created for adults and then downward extended for children. When we're looking at neurodevelopmental disorders like autism that are unfolding in the first year or two of life, we're finding that the risk signs for autism aren't necessarily the presence of those atypical behaviors listed in the diagnostic criteria, but rather the absence of typically developing milestones that we would expect to see. These are things like vocalizations and speech. Babies are very vocal. Starting around 3, 4, 5 months of age, they start babbling. The babbling turns to jabber, and it's very reciprocal with a caregiver. You'll hear ba 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 ba, and the mom goes, "That's right, Baba. You want your Baba? That's right. I'm Mama. That's Dada." And it's a reciprocal dance. In autism, you'll see atypical vocalizations, so not really a lot of consonant vowel blends, but rather high-pitched vowel sounds or odd repetitious consonant sounds. And then if the infant is babbling, it's not necessarily reciprocal. There isn't that back and forth with another person. And what ends up happening is there's some research to show that parents, when they're trying to get that reciprocity, they end up stopping because they're giving up per se. And then you'll see a trickle down effect where the infant then stops vocalizing. And so you see autism begetting autism. And then infants, before they even develop speech, will be communicating with their gestures, with their facial expressions, with their eye contact to get those needs and wants met for survival. But even for social interaction, they are going to be pointing to show from a high chair. They're going to be showing things just for the fact, do you see this cool new thing, Dad? Are you looking at this with me? Joint attention. In autism, you will see limited use of those nonverbal communication behaviors and definitely a restricted range of them. And then infants also aren't responding to their name. That's very social language. So if you have a social disability, you're not responding to your name. And you're also not monitoring your social world. When you don't monitor your social world, you don't model or imitate your social world. And imitation is a building block of learning. And if you don't have imitation skills, you're not learning. So the lack of imitation skills is something that we see often in autism, and it would be a risk factor. And then because autism unfolds over the first few years of life, infants don't come into the world at birth with full-blown symptomatology. What happens as the development is going awry, there were some behaviors, or usually there can be some behaviors that are actually developing. The child has good eye contact, a social smile. They are vocalizing and babbling. But then as the autism unfolds, that goes awry. And now in retrospect, it appears from a parent's perspective, and understandably so, that that's a regression or loss of skills. So anytime a parent reports that their child has had a regression, that should be a risk sign for concern. On the flip side, we are diagnosing and doing evaluations for many more older adolescents and adults. This is because the diagnostic criteria have broadened so much and now include so many individuals who have no cognitive impairment and no language impairment, and they're getting missed from childhood, Or they have more prototypical symptoms, but given the changes in our diagnostic criteria, they were missed in early childhood because they didn't actually meet criteria. Some of these individuals were actually evaluated as children, but someone said they fell below the threshold and were never given the diagnostic label that now has changed, and they would fall under it. Also, when you have these individuals that are more likely to have intact cognition and language, they're more likely to mask and camouflage. We'll talk about this more in a minute, but this is when you have observation skills enough to fake it till you make it. You're going to pretend or put on an act as if you're not missing the boat, as if you're not confused and don't understand the social interactions and the nuances. And yet this is really debilitating. People describe the masking and camouflaging as exhausting, and that it leads to really increased symptoms of anxiety and depression. And then also, if you have an autism spectrum disorder, which remember is a social communication interaction disability, you haven't been taught more functional means and appropriate means to communicate that are successful and effective. But we all need to have our needs and wants met. So we will communicate in aberrant ways, right? We're going to hit and scream and cry and bite and headbang and do and have meltdowns, do whatever it takes to get those needs met. And the older an individual is, the more time these maladaptive behaviors have become entrained, and the harder it is to undo those behaviors. They're never supposed to be assumed to be malicious or intentful. They're not. They were manifesting for a reason, and then they became effective. And therefore, we never want to assume that these are quote unquote bad behaviors that just need to be eliminated without thinking about the why. Why are these behaviors arising, and what other means can we use for intervention, like teaching more functional communication? And now we'll talk about variations in cognition and language. Many of you clinicians are very familiar with the bell curve and understand that intellectual disability is defined by delays in both cognition and adaptive behavior, using standardized measures, usually with a standard score falling below 70 on each of those measures. That's about 2% of the population, right, that are off the norm in the ID range. What we often forget is that those individuals on the other side of the bell curve, that 2% that's just as off the norm, who have IQs above 130, they're not going to be anything like their peers. They're going to struggle in social situations with their peers because they're nothing like them. They don't share the same interests. They're likely going to get along better with adults because the adults are more on their wavelength of their interests and their intellect. And there can be a lot of overlap then with autism symptomatology. So these are the things that we want to keep in mind when we're doing these diagnostic differentials, that when we're giving our quote unquote gold standard measures, for instance, like the autism diagnostic observation schedule, which is used in diagnostic evaluations for autism. Really gifted individuals who are highly verbal and have really strong conceptual skills can fall sub-threshold on something like the ADOS, even if they have autism. And then on the flip side, if someone has profound intellectual disability or really global developmental delays as a young child, they can, and they don't have autism, they can fall above the thresholds for autism symptomatology on our autism measures. So we really want to be careful. Again, no single measure diagnoses autism. Just because these things can occur doesn't mean that's our diagnostic outcome. And just understanding that these presentations can be really complex to try to weed apart. And that's why it's so important to do comprehensive IQ testing, for example, because if we gave a brief IQ measure, we're going to wash out a lot of the variability to truly understand if someone has certain areas of deficit and certain areas of extreme strength. And just another thing to say about gifted intelligence, many of you are already familiar with this because you work in the field and you know about twice exceptionality and even just people who are off the norm with gifted intelligence. That can come with its downfalls. There can be a lot of anxiety and stressors and behavioral dysregulation, executive functioning impairments, and even ADHD when you have gifted intelligence. So a lot of that can overlap with the autism symptomatology as well. Therefore, when we're doing these assessments, doing comprehensive developmental assessments for infants and toddlers is really important. And probably the most widely used and most up-to-date norm infant scale is the Bayley scales of infant development, which is currently in its 4th edition. The only thing is the Bayley only goes up to 48 months. In academia, the Mullen scales of early learning have been used more widely and more broadly in the field, but the norms are very outdated. They're from like 1990. That said, it's also important to know that in our field of cognitive assessments, as psychologists, we really don't have good measures to assess severe and profound levels of intellectual disability. So when someone is really cognitively delayed, we don't have standardized measures at their chronological age that they can successfully complete. And for that reason, we might have to resort to an infant toddler measure like the Bayley or the Mullen when we're assessing an older, more impaired individual. So if I have a 10-year-old, a 25-year-old, or even a 50-year-old that I cannot give any other standardized measure to because their mental age is at about a 2.5-year level, that I'm going to resort to one of these developmental assessments. And I can develop a ratio IQ to estimate what their intellectual capacity is. And then we can also look at that in comparison to adaptive behavior. When we look at older individuals and we're looking at measuring cognition or intelligence, again, we have a variety of instruments to choose from. You all have your favorites and they're all wonderful. The one thing I would like to say, just for caution in the field of autism, you're dealing with social communication impairments. Even in very bright individuals, understanding complex language can be a challenge. Things like the Wechsler tests and the Stanford-Binet and other measures, they're really strongly verbally loaded. Just even think, for those of you who are familiar with the instructions for letter number sequencing, for example, it's very complex. Even if the individual knows how to do that task, they have the intellectual capacity to perform that skill. The instructions are so long and complex, you've lost them. They don't understand what you're expecting of them. And that's why measures that actually have teaching items and demonstrations, letting you as the examiner model what's expected of them, those can be more effective. And the differential ability scales, which is in its 2nd edition and was just recently normed for the school age, renormed for the school age, the DAS or DAS, however you like to call it, can be very, very beneficial in autism. Interestingly, in the field of autism, you can actually look at Wechsler profiles because so much of the research on cognitive profiles in autism has been done on Wechsler scales. This is just a sample from one of the books that I wrote. This particular page was published in the 2012 edition, which preceded the DSM-5. So there were still subtypes of the category of autism, including Asperger's syndrome. Asperger's syndrome is no longer a subtype in the DSM-5. It's subsumed under the spectrum of autism. And yet this book was just updated and published a couple months ago. So the updated one does not include this. But I just wanted to show it to you because it does show these profiles. For those of you who give the WISC-5 or even the WACE for individuals on the spectrum, it's not diagnostic, but it can inform your diagnostic conceptualization when you see this scatter. Within the verbal domain, information is facts that never change. That will be a strength in autism, no matter what the person's level of functioning is. Vocabulary and similarities will be a strength for your high verbal autistic individuals. But comprehension, which has now been relegated to a supplemental subtest on most of the Wechsler scales, is one of the most informative subtests for autism because it's social problem solving. So every time I give a WACE, for example, I use the comprehension subtest, and I just have it there just for my own information to see if this comes significantly lower than the other verbal subtests. Within the nonverbal reasoning, you will see matrix reasoning or pattern completion being a strength. Autism loves patterns and sequencing and abstract designs, parts to whole reasoning. So matrix reasoning and even block design can be your highest. But if someone has visual processing impairments, more like a nonverbal learning disability, but also autism, or they have fine motor control vulnerabilities, then you'll see block design being a weakness because it requires that visual motor integration. Working memory, auditory working memory, things like digit span and arithmetic really depends on the individual. But processing speed, the subtests under processing speeds index usually are your lowest in autism across the board. And this is not because autistic individuals tend to have slow processing speed. It's because time concepts are very abstract and they don't tend to pay attention to time constructs. So you as the examiner can give all of those instructions to be like, work as quickly as you can, don't make any mistakes, and one after the other. And these individuals will still work very methodically. They might perseverate on their drawings. They might be chattering about their circumscribed interests and trying to talk to you as they're doing the paper and pencil task. And all of this slows down their overall speed. But usually they're very accurate in those tasks, but they're slow in speed. And then, like I said, the differential ability scales is just very useful and often used in the field of autism because of the teaching items and ability to model and demonstrate the items. Also, because the early years battery, those easier subtests, the norms go all the way up to age 8. So you can use it for older, more delayed individuals and still get your standard scores. Now that we have a cognitive or developmental profile, we want to do standardized assessments of adaptive behavior. And the Vineland, many of you are familiar with, looks at adaptive functioning in the primary areas of communication, daily living skills, and socialization skills, because these 3 areas match what's listed in the DSM-5 as areas of delay required for intellectual disability. The motor scales are optional on the Vineland 3. Even if you choose to do them, they are not included in the overall adaptive behavior composite. And that scale only goes up to age 9, whereas the rest of them are the lifespan. The thing about profiles of adaptive behavior, just like profiles of intellect, you are going to see scatter. Scatter is the norm. So we really are very rarely interpreting an overall composite. I should have said that about IQ scores too. We very rarely look at a full scale IQ because of the scatter that you'll see across the profile. And if you give these abbreviated tests, you're washing out that scatter. When we're differentiating cognition for adaptive behavior, think of cognition or intellectual ability as capacity. These are the skills that an individual has the capacity to perform. Adaptive behavior is, does the individual actually perform that skill when life demands it? These are everyday practical skills. A lot of neurotypical individuals, if they have the cognitive capacity, they usually apply the skill. So your intellectual abilities and your adaptive behavior are usually on par with one another. However, in autism, this is not the case. Adaptive behavior will usually fall lower than chronological age and cognitive capacity for primarily individuals who have no cognitive or language impairment. When we're looking at individuals who have severe and profound intellectual disability and co-occurring autism, those individuals' adaptive skills are still delayed for their chronological age, but they're usually on par with or better than their mental age. And that's probably an intervention effect, because we as clinicians are far more frequently recommending everyday practical skills when we diagnose intellectual disability. However, we fail to do that for whatever reason when we diagnose autism in these individuals with high cognition and language, thinking, well, they must have the capacity to do all those everyday practical skills. Yet they don't, because remember, they're not monitoring their social environment. Adaptive behavior is very, very socially based. And the gap between cognition and adaptive behavior widens with age. So individuals, despite how bright and verbal they are, they're not keeping pace with their everyday skills the way they're keeping pace with cognition and even chronological age. When we're looking at how broad the spectrum is right now, it's very, very broad. The common thread are the autism symptoms, right? Social communication interaction challenges with the presence of restricted and repetitive behaviors. But now we have varying levels of cognition, varying levels of language, varying levels of symptom severity, varying levels of behavioral dysregulation, and then varying levels of co-occurring conditions. When anyone talks about levels of functioning, they're usually talking about IQ. High functioning autism, for example, historically has really just meant autism without co-occurring intellectual disability. Asperger's syndrome as a former subtype, the diagnostic criteria stipulated that there was no history of a language delay and no cognitive impairment. So that just fell on the quote unquote high functioning end. When we use terms like this, though, it can be misleading, which I'll talk about in a minute, that we want to do away with terminology, high functioning and low functioning, rather just use language that specifies what you're actually talking about. High language, minimally to nonverbal, high cognitive, gifted intelligence. When we're looking at individuals who have co-occurring intellectual disability with autism, those individuals are more likely to have medical co-occurring conditions, seizures in about 15 to 25% of cases, depending on the research, co-occurring genetic disorders, or just unidentified genetic mutations. There could be cardiac defects, there can be metabolic issues, a whole host of things depending on the profile. Yet on the flip side, in the individuals with intact language and cognition, those individuals may have more insight and awareness into their challenges, which means they're more prone to anxiety and depression because they're more at risk for fixating and ruminating on their failed experiences. What ends up happening is, as the diagnostic criteria have broadened over the past 50 years, which they've broadened tremendously, we've gone from having a categorical disorder, classic autism, right, that was very distinct from typical development. You knew that was a clinical disorder. But today, it's much more blurry. What actually is autism or neurodiversity in individuals who have intact cognition and language versus neurotypical development? And this can be very, very challenging and also very controversial within the field, because you have neurodiverse self-advocates who have the capacity to speak for themselves and say, I'm different, not disordered. There's nothing wrong about me. Don't try to cure me or change me. Versus the parents, family members, and caregivers of those who are severely and profoundly affected, mentally to nonverbal, that have severe self-injury and or aggression and behavioral dysregulation. Those deficits, the family members are absolutely saying, I want to find a cure for this. I want this, I want intervention for my child. And so these different viewpoints are at odds against each other, and it's become really controversial in the field. So much so that the parents and family members pushed to have a subtype of severe and profound autism come back into play. And that actually did. So in 2021, the Lancet Commission formally recognized the term profound autism for those individuals who are the ones that need lifelong care. 24/7 lifelong care. And then what's just as controversial in the field is, how do we even talk about and to individuals on the autism spectrum. Do we use identity first language? I'm an autistic person, that person's autistic, versus that's a person with autism, or I am a person with autism. This has gone circle to circle to circle since I've been in the field. And it, even to this day and age, neuroadvocates tend to prefer identity first, I'm not disordered, versus parents and family of the severe and profound who say, no, it's my child has autism. This is a disorder. But don't make that a blanket statement, because there are many neurodiverse self-advocates that use person first language, and then there are certainly other families that use identity first. As a clinician, I just recommend asking your audience what is their preference, and try to respect that and use that. And you'll probably hear me bounce back and forth because this is a wide audience and I don't know the preferences. Then going into sex and gender differences that can also be really complicated. When we think historically about everything we know about autism, even the DSM criteria, it's all been created based on research on males, because historically we're looking at a disorder that's 4 to 5 times more prevalent in males. When you're in academia, those of you who do research, you understand this very well. If you're in a small academic environment, no matter how wonderful the research you're doing, you work years and years and years to collect all of this data, and then you have 50 a sample of 50 individuals and only 5 of them are female, you can't do any statistical analyses with those. So you drop the females from the analyses and all of the research is only done on the males. That's 99% of the historic research in autism until more recently, when studies started doing consortium collaborations and pooling data. And then we started learning more about autism in females. Also understanding that if you're only looking at research has very high standards about cutoffs on measures, and you have to have pretty severe symptomatology to meet those cutoffs. Females who we're learning have sometimes more subtle symptomatology. They're falling shy of the thresholds. They were never even making it into the research in the first place. Those that did were so impaired that they ended up being on the more impaired end of the spectrum, making researchers think that if you were affected and you were a female, you were going to be more severely affected. But what we're learning now is that females, especially those with intact cognition and language, can have strong social motivation and reciprocity. Because of that motivation and reciprocity, there's more social monitoring and imitation and modeling. And that's where masking and camouflaging comes in. They're able to observe and mimic other people. Their circumscribed interests and their fixations could be more normalized, quote unquote, in that classic autism in males, it's trains and dinosaurs and, things and objects. With females, it tends to be more people, characters, animals. That seems to be more naturalized. So when someone sees that behavior, yeah, it seems intense, but not atypical, that can't be autism. And then they fall sub-threshold. And then there's the female protective effect. So looking at genetics, when you identify genetic mutations in females, they tend to be larger mutations than the same symptom expression in a male, meaning that they're taking a harder hit. So there is some protective effect there. And then when we think then on the higher cognitive, higher language end, that masking and camouflaging is also a protective effect. However, we're learning that the act of camouflaging and masking is exhausting. There is a measure called the Camouflaging Autism Traits Questionnaire, the CAT-Q, that looks at this in individuals over the age of 16, but I believe the researchers are downward extending it because masking and camouflaging certainly occurs in younger individuals, where it's a self-report, and these individuals can actually report whether or not they're doing these behaviors. And then the COVID-19 pandemic was It brought us all together as clinicians and researchers in that we had to scramble to find ways to conduct diagnostic evaluations for autism virtually, which so many of our measures had to be done in person. Because we were all collaborating virtually, and not just within the United States, but around the world, there were so many papers that came out of the collaborations with academics. And one of those, after writing papers about autism assessments, for example, during COVID, there was a group of us that continued to have monthly meetings talking about other challenging issues that we're all struggling with, regardless of COVID. And one was the female presentation. And we wrote this paper that got published this past year, really looking at what is needed in the field, and like a call to attention of better understanding assigned female at birth, and we'll talk about gender fluidity in a minute, but really the complications from detecting autism in girls who are infants and toddlers all the way up through adulthood. And now, as we broaden the spectrum and we have more and more individuals who have intact language and cognition, who can talk about their experiences, we're seeing there's a lot more gender fluidity and sexual diversity. So when we look on both sides, if we look in the LGBTQ plus community, we're seeing more autism traits, specifically in transgender individuals. And then when we look in the autism community, we're finding more LGBTQ plus, specifically transgender individuals. Now, we don't want to assume that those camps are identical. They're likely not, and likely different for very different reasons. Again, individuals who are experiencing gender dysphoria and going through a gender transformation can have a lot of anxiety, can have a lot of difficulty with their peers. They can have a lot of challenges that overlap and murk the waters when you're trying to think about something like an autism presentation. Whereas when you are already identifying the autism and then exploring gender and sexual identity, then you're seeing more fluidity. It's become so much of an increase right now that I, as a clinician, every time I do a diagnostic evaluation with anyone who's of age that I feel has the capacity to talk about their gender and sexual identity, I include those questions in my diagnostic interviews, because I want to know if any of those factors are murking the waters. If someone's gender dysphoria, for example, is causing anxiety versus the limited social competencies. And here are just some resources. More and more will be coming down the pipeline because this is such a new area of research in our field. And then we have conditions with overlapping symptomatology. And there's so many. And for the sake of time, I just want to, we can always answer questions in more detail, but ADHD is one of the most complex in overlapping. And this is because, again, inattention, hyperactivity, and impulsivity are all subsumed under autism, but they can present very differently. Inattention in autism can be in ADHD, I'm sorry, can be a difficulty focusing your attention, whereas autism, it's an overfixation on things, objects, and even topics. So it can be intrinsic fixations, not external. Medication can help inattention. Medication does not help overfocused attention. Impulsivity, similarly in ADHD, is a lack of impulse control, where someone says or does something that comes across as inappropriate or odd or hurtful. Whereas in autism, someone can do or say something that's inappropriate, odd, or hurtful, but that's limited social awareness. That's lack of perspective taking that what I just said or did is going to affect you as a person. Medication can help impulsivity. Medication cannot help limited social awareness. And then hyperactivity individuals with ADHD can jump and flap their hands. They can have stereotypical motor mannerisms, just like you see in autism. And then there's executive functioning impairments that overlap. executive functioning impairments are very frequent in ADHD and very frequent in autism. And there's this one interesting study that shows you're going to see it across both disorders, but what seems to be more specific to autism is inflexibility and difficulty with planning, and what's more specific to ADHD is response inhibition. And then there are just lots of measures for executive functioning that I will do a screener as part of my diagnostic evaluations. And then social emotional functioning. I'll use the BASC or some other measures to look at profiles of self-regulation, anxiety, depression. I want to do a screening to see what should I be taking a deeper dive into. And what I love about the BASC, in addition to the clinical scales, you have your content scales. So this just helps. It's another tool in my toolbox. If I see the autism probability raised, but only autism, then that's helping me think one way. But if the ADHD is also raised, then are we looking at a differential versus a co-occurring? And one of the most challenging, in my view, for my older adolescents and adults who are seeking a diagnosis for the first time is the overlap with social anxiety. There is so much overlap here, and we don't have time to go into all the nooks and crannies, but really, social anxiety is a phobia. What's distinct about it is these individuals have a very common theme of fearing negative evaluation of others, and they flee the situation to avoid that feeling, or they endure it with extreme distress. Autism, it's anxiety because of a limited competency. They don't understand the nuances of the social interactions. They can't keep up. They don't understand the sarcasm and figures of speech and literal language, figurative language. They just don't get it. And certainly you can see the overlap here. Both are going to be withdrawn. Both are going to avoid. Both are going to have anxiety. Both might have poor eye contact. But when you really piece it apart, that fear of negative evaluation is social anxiety, and the limited competency is autism. Again, having a screener for anxiety as part of your evaluation can be helpful. And then assessing speech, language, and communication. If any of you are speech pathologists, you have so many wonderful tools in your toolbox to go from very basic forms of language to the real non-literal nuances of language. And we have in the DSM-5 this social pragmatic communication disorder, which if you look closely is really just the first component of the autism criteria without the presence of restricted and repetitive behaviors. This is pragmatic language, social use of language. So you wouldn't be thinking about this in children under the age of 4. And finally, I just want to talk about how disparities affect our diagnostic formulations. There are so many disparities in the field. Historically, Black and Hispanic children have been missed. They've been misdiagnosed, usually with those bad kid labels: oppositional defiant disorder, conduct disorder, disruptive behavior disorder. They are getting poor access to healthcare services. We're learning more and more that these disparities exist, so we're getting better at identifying autism in minorities. And for the first time in our most recent studies, we actually were identifying autism more in Black and Hispanic children than white children. But we still have a long way to go, because when we break it down by intellectual disability, 50% of Black children are meeting criteria for intellectual disability versus only 32% of white children. That's not a genetic disparity. That is an ethnographic disparity. That's something we can fix and something we can do about. That's all about limited access to care. And that brings us to socioeconomic disparities. So it's not always just about race, but it really blends in with socioeconomic status. People from disadvantaged communities have less access to care. And families who have more means can doctor shop. They can skip wait lists. They can get the appropriate diagnosis, where those from disadvantaged communities cannot. And then one thing I'd love to just highlight here, there is a biomarker right now for autism. It's an eye tracking device that is used as a diagnostic assistive tool, where it's for very young children, 16 to 30 months. They can watch videos, and at the end of 10 minutes of watching videos, it will say whether or not they meet criteria for autism. During the FDA trial for that study, there were 7 or 8 sites across the United States with expert clinicians in these academic sites conducting the diagnostic evaluations in person and then comparing it to the biomarker eye tracking. The clinicians had a bias. They were more likely to diagnose Black children with autism, yet the FDA, the biomarker, the device was blind to race and ethnicity. So we as clinicians really have to pay attention to our own biases, whether or not we're even aware of them. With that, I know I threw a lot at you very, very quickly, but I wanted to leave ample time for questions. Just in summary, these are the things: age, cognition, language, sex and gender, and overlapping symptomatology and biases that can murk the waters, and that we have a tough job, but hopefully these are some tips that can be helpful. So with that, I'll first thank you all for attending. There's a large group here, and then want to pass it over to Pearson to start getting some questions.
Great, thank you so much. We did have a question about what age it's typically diagnosed in kids. I think you had mentioned typically around age 4 to 5 in boys. What is the average age for girls, and how many older? I'm kind of combining a few questions. How often are you seeing older people, 15, 16, older, or even older than that, being diagnosed?
Great question. So the rate in females, I don't know that off the top of my head, but it's definitely way less than males. And so the average age of diagnosis of a female, I don't know the answer to that, but I know it's going to be way older than 4 or 5. And the rate of diagnosing adolescents and adults, this is anecdotal, but I'm in private practice. I left academia in 2018. I should say I didn't leave academia. I left my academic job and started my private practice in 2018. In the past almost 6 years now, I've primarily only seen adolescents and adults seeking a diagnosis for the first time. So it's probably 90% of my clientele.
Great, wonderful. We've had a lot of questions, and I know you touched on this a little with females. Have you seen a big increase in women and girls being diagnosed with autism spectrum disorder? And how has that gotten more challenging with masking? And I know you've touched on this a little bit. Anything you can do to elaborate? We've had a lot of questions on that topic.
It is very hard because you want to know how much insight they have into their masking and camouflaging. Diagnostic evaluations, you need collateral information. I'm not just talking to the individual themselves. Even for my adolescents and adults, I require someone else participating in the evaluation, usually a parent, but if a parent's not alive or not available, I ask for a family member. So this week, I evaluated a 47-year-old and I had the brother. So I'm gathering a lot more information than just their perspective, because that perspective could be impaired. Also, just the co-occurring conditions, right? Because the masking and the camouflaging are exacerbating anxiety, for example. So I'm doing all of the assessments for the typical co-occurring anxiety disorders to see which one do I think is causing the masking, because other people can mask too. It's not just autistic people masking. People with anxiety can mask just as much. And another thing that I want to say here, I should have had a slide for this, is that social media doesn't help us out. There's a lot on autism on social media that's wonderful. It increases the awareness and it gets people talking about autism. But there's a lot out there that's false information. And my colleagues at Drexel did a study this year where they looked at the most commonly viewed videos on TikTok and found that only about 29% of the content viewed in those videos on TikTok were accurate, and about 47% of the content was actually inaccurate. And a lot of times the adolescents and adults that are seeking a diagnosis for the first time, it's because they saw something on TikTok or social media that resonated with them. And I end up not giving a diagnosis of autism. It's usually anxiety or PTSD or something else. And they can get really mad because there's something about clinging to this autism label that people find as an identity, which to me is really intriguing because, as a clinician, this is a clinical disorder. This is not an identity or personality, and that can be really challenging to have those discussions with clients.
Great. I'm really glad you shared on that because we have had that come up with the impact with social media, and a lot of people have actually put questions in the chat about that. So I'm glad you touched on that. We also have a lot of chats about our questions in here about different, comorbid conditions. So I know there was a few questions about, potentially looking at something like a WISC profile and comparing intellectual disability to autism spectrum disorder and how that might look differently. And again, other questions around overlapping symptoms with anxiety, ADHD, and autism spectrum disorder. So how do you sort through all of those when there can be multiple diagnoses, where there can be overlapping symptoms? What have you found helpful in guiding that decision making?
Of course. To me, the easiest one is intellectual disability because remember, autism is a social disability. So if someone has autism and they have intellectual disability, their social functioning will be lower, more delayed even than their mental age, more delayed than their cognition. That's why the adaptive behavior assessments and the assessments of social functioning are so important to give on top of IQ. Because if I have a 10-year-old that's functioning at a 7-year mental age and their social functioning falls at a 7-year mental age, I'm thinking that's more intellectual disability. If someone's 10, their IQ is functioning around a 7-year mental age, but their social functioning is at like 3 or 4, that's prototypical autism. It's harder when you get things like ADHD, right? Because there's so much more overlapping symptomatology that certainly individuals with ADHD can have social sequelae. They can be ostracized from their peers. Peers can't tolerate the impulsivity and hyperactivity. So there's a social fallout, but the foundational social competencies are there. Those are stronger than what you would expect in autism plus that ADHD.
Great, that's super helpful. What measures do you use to help differentiate between social problems related to autism and social problems related to giftedness? How do you determine if a gifted individual also has autism spectrum disorder?
That's when I'm doing my autism specific measures. The gold standard is the ADOS, the Autism Diagnostic Observation Schedule, and I'm also doing a very comprehensive developmental history with a parent, ideally, right, or a family member. It's those two things. If someone's just gifted intelligence, their foundational social competencies are there. And when I'm interacting with them in person, they're much more reciprocal. They're much more fluid. They're integrating their eye contact and gestures with their speech. It's very natural, but they might be idiosyncratic. They're using vocabulary words way above my understanding. They can be a little rigid and arrogant in their, I'm always right kind of thinking, which can be common in giftedness. And then I have nothing in common with my peers. I just have no interest in my peers because they've never met that other 2% of the population that's like-minded. And then from a developmental perspective, those kids, interestingly, can have social struggles as early as preschool, because at the preschool age, these gifted kids can be already well advanced and reading and writing way beyond their peers. And so they're skipping grades and they're, getting put into gifted classes, or they're not because they don't have access to that. And then they're disruptive because they're either acting out because they're, they can't stand their placement, or they're bored. And a whole lot of behavioral things can become intertwined there. So I'll be giving things like, if it's a young kid and I'm looking at giftedness, I'll be giving things like the BASC and the autism specific measures and doing all the collateral. And the older individuals, you're getting their history, but you want to get history from someone else too. And those foundational social qualities will be there.
Well, that was wonderful. Thank you so much. I know we're out of time. I think we could probably ask 100 more questions if we had time, because there's so much interest in this topic, and this was really great. So just want to say thank you for being with us and sharing all this information.
Oh, of course. And thank you all for attending, and thanks to everyone at Pearson.